Hello everyone and welcome to my channel. In today's video, I'm planning to talk to you about the duties and responsibilities of a clinical pharmacist. Now, this is mainly what we do here in North America, but it should be the same everywhere else in the world. So hopefully, after you watch today's video, you would get the sense of what a clinical pharmacist is required to do on a day-to-day basis. Now, if you're new to my channel, this channel talks about clinical pharmacy, how to become a clinical pharmacist, and I have a complete clinical pharmacy free course on my channel. And I also have my clinical pharmacist book if you're interested in purchasing that. But all the videos on my channel are free. Feel free to navigate through. And if you're new, make sure to subscribe to the channel if this is a topic that you're interested in. There are so many useful videos on my channel that should help you become a clinical pharmacist in a very short period of time. Now let's get started with today's video. There are so many duties and responsibilities for a clinical pharmacist. We do a lot of things on a day-to-day basis, and many of them are basic pharmacy duties, but there are also specific duties that a clinical pharmacist would do on a daily basis, whereas a staff pharmacist would not have to do, such as, for example, the medication reviews that we do on a daily basis. A dispensary pharmacist doesn't have to worry about that because we do it. Although, in my opinion, every pharmacist should be able to do the medication review and should try to do a quick medication review for every single patient they see on a daily basis, because it helps a lot understand the medications. So if they do a medication review, if they're reviewing the case as a full, it helps them understand what the patient is using these medications for, especially if a patient is on like 15 or 20 medications and you're like, you have to verify all these as a staff pharmacist, but you don't know, okay, there are so many things. There's an anticoagulant, there's something for high blood pressure, there's something for diabetes. It looks like this patient has hypertension and diabetes and something that needs an anticoagulant, and so on. So when you do a full medication review, you would understand more, and it helps you confirm your idea whether to verify an order or not, or talk to the doctor about something that pertains to that order. Now let's get started. So first of all, what is clinical pharmacy? So the American College of Clinical Pharmacists, or American College of Clinical Pharmacy, defines clinical pharmacy as an area of pharmacy concerned with the science and practice of rational medication use. Okay, that's pretty broad. So to simplify it, clinical pharmacy is a health science discipline in which pharmacists provide patient care that optimizes medication therapy and promotes health and disease prevention. So basically, your main job is to optimize medication therapy, and of course, do some health education, and education to prevent diseases. Let's talk in detail about that. In general, you as a part of a team, as a clinical pharmacist and part of a team, your main job is to make sure that the patient is getting the right medications, optimizing therapeutic plans, answering drug information questions, and many more duties that you do as part of the team. But it's not like you have to do all of them at once. So let's discuss one by one. So the first thing that you might be, or you might see us doing, is consulting with physicians. We actually do not just consult with physicians, we also do consultations with nurses, with other health professionals as well. So consulting with physicians is the main daily thing that we do, but you might also get asked about drug information questions from nurses, from dietitians, from physiotherapists, many other health professionals as well might ask you questions on a daily basis, so you need to be prepared for that. So basically, as a clinical pharmacist, you are expected to work with a team of physicians, nurses, dietitians, physiotherapists, and other professions, okay? Whether it's at a hospital or at a clinic, doesn't matter. You still have a team. The only difference or the only exception would be if you're working as a clinical pharmacist in the community, like in a community pharmacy. You might not have a team then, but other than that, in hospitals and clinics, you probably will have a team, and you'll be practicing with them. Most of the time, you will start your day every day rounding on patients with that team. So a team of one doctor or more, and some nurses, and yourself, and a dietitian, and a physiotherapist. All together, you go and start rounding on patients. You need to have an excellent knowledge of medication, that's for sure. Questions will arise, and they will ask you, and because you're the pharmacist, so you need to know and answer their questions as soon as possible. But it doesn't always have to be immediate answer. Like, you can look it up, you can tell them, okay, give me time to research it, if you don't know. But if you know off the top of your head and you're 100% sure of your answer, then you can answer immediately while rounding on patients. One more thing you need to know is you need to be aware of the most current guidelines of treatment of different disease states. So when you're rounding on patients and you come across a patient who's, say, a diabetic patient, a type 2 diabetes patient who is on all these insulins, not on oral medications, nothing. So you need to question that. If it's really truly a type 2 diabetic patient, why is the patient on all these insulins and not on oral medications? So you'll see things that don't make sense unless you know and you're aware of the guidelines of treatment in the country you're practicing. You wouldn't know, right? You would just accept it. Okay, the insulin is controlling his diabetes, so we'll just leave it. But we're not following any guidelines, so that would be actually an error. And yeah, if you know the guidelines, you'll be able to talk to the doctor and tell him, hey, what's going on here? Is this patient, and look, has this patient tried everything and failed it, and that's why they're on insulins now? Is it truly a type 2, or should we investigate in type 1 diabetes? And so on. A physician or other health professional might actually consult you on a patient's medication or list of medications to see if any changes are warranted. And this is how we optimize treatment plans. Actually, we can either remove a medication that is not necessary anymore, add medications that are important for the case, or adjust doses to optimize the therapeutic plan. Most of the patients that you'll see are admitted to either an acute care setting or a long-term care setting. That's most of the patients we see in a hospital or a long-term care facility. So you will need to do a medication review for every single patient and come up with a plan to discuss with the team. The goal of your plan would be to optimize the patient therapy. After that, you need to document this plan somewhere. So if your hospital or clinic, wherever you're practicing, uses like a charting system, then you have to document your plan in the chart. And if they use a computerized system, then you have to document in that computer system. And the reason why you have to document your plan is because people need to know that we made some changes to the patient medication in the future when they pull up the patient's profile, and then see if that plan actually worked. Do we need to do something else? Do we need to continue titrating a specific medication? Do we need to stop any medication that actually caused us problems, or caused the patient problems, etc. So yeah, documentation is important. Also for liability, you have to document everything. And yeah, that would be the last step, to document, and then there will be a follow-up plan to see if the medication is actually working, if the patient is having any side effects from the medication, and so on. So this is basically what happens in a consultation when the physician or a healthcare professional consults the pharmacist or the clinical pharmacist on any single patient. And of course, this does not take 5 minutes to finish. A pharmacist consultation would take at least an hour, because you have to dig into the history of the patient, you have to gather enough information before you can actually make an informed decision, and then you have to counsel the patient and talk to them to see what happened in the past, how they feel right now, how they feel about the new plan that you are planning to implement, and more. So yeah, this takes at least an hour for your consultation. So it's not like a verbal consultation. Hey Joe, somebody calls you. Hey Joe, I have this patient. He's 65 years old, and he's got diabetes and hypertension and congestive heart failure, and I want you to recommend a drug. No, this doesn't happen in the real world, because you have to dig more into it. You have to get some lab information, some imaging information to understand the case very well before you can actually make recommendations. So don't ever think that a pharmacist consultation can be done verbally, immediately on the spot. This can actually lead to errors, so you should be very careful when you do that. Now let's move to the next duty for a clinical pharmacist. This one is going to be very interesting. Now, one of the main duties of a clinical pharmacist is to individualize patient medication therapy. And this is very important. Now, I'm going to tell you in a second why it's very important. Of course, you have to reference literature and publications, and look at the guidelines, review patient charts, laboratory test results, imaging results, and more and more. Sometimes we face multiple medication-related issues on any patient's profile. While we usually find out while doing the medication review on the patient. For example, you might notice therapeutic duplication, or a drug-drug interaction that is a pretty serious one, or a drug-disease interaction. Physicians usually tend to prescribe drugs that worked in the past for other patients they treated for the same disease problem. But we know that drugs are not one size fits all. We need to individualize therapy based on many factors. I'll be talking more in detail about that in future videos where I discuss different cases of patients. But in the meantime, let's take this example that you can see on the screen. So a 65-year-old patient gets admitted for hypertension control. His blood pressure on admission was 220 over 100. That's pretty high. And all measures have been taken to lower it on this admission, which included intravenous antihypertensives at first. So the patient received intravenous antihypertensives, and they've started lowering the blood pressure. This patient does not have any past medical history and does not use any medications at home. So this is pretty much his or her first medical condition that led to admission to the hospital, and they had no history before that, no medical history before that. Now the blood pressure is stable at 160 over 95, and the physician initiated diltiazem 120 milligrams long-acting pill daily. After a few days, the blood pressure is now sitting at 135/80, so it dropped even more. So it seemed that the patient has responded quite well to diltiazem, right? The patient is now discharged from the hospital, and there's a follow-up appointment in a week at their doctor's office. So this is a very easy case. Patient comes in, they have hypertension, we control it, or I should say hypertension emergency. We controlled it. We initiated a new drug for the patient because they don't have any history, and it acts very well, controls the blood pressure, and then we discharge the patient. They don't have to stay in the hospital anymore. Now let's take a look at the next case. A week later, after this patient, another patient comes in to the ER with a blood pressure of 220/100. Very similar, right? The patient is also 65 years old and has a medical history of congestive heart failure with an ejection fraction of 25% and diabetes. So this patient has past medical history now. His medications at home included amlodipine 10 milligrams daily, furosemide 40 milligrams daily, glyburide 10 milligrams twice a day, and linagliptin 5 milligrams daily. Right now, I'm not going to talk about optimizing therapy because this we will discuss in another video, but because we're talking about individualizing patient medication therapy right now, we'll focus only on that. Now, the blood pressure was lowered in emergency department, and the physician would like to start diltiazem long-acting pill again. Now, remember, it's the same physician, it's the same unit, the emergency department, same case, patient 65 years old, same blood pressure on admission, and why not start the same medication, right? He calls you for advice. Now, this time the doctor called you for an advice, and he wants you to give your input on this patient. Should we go with the same dose of diltiazem as the previous patient? So, what do you think? Should we start diltiazem 120 milligrams long-acting daily on this patient as well, considering that this patient presented with exactly the same problem, high blood pressure, similar age, and whatnot? Or should we do a different dose of diltiazem, or should we do a different drug altogether? Like, what do you think? Let me know in the comments, and I'll be discussing this case in detail in another video. But this is an example of individualizing patient medication therapy. Alright, let's move on to the next point here. Point number 3, under duties and responsibilities of a clinical pharmacist. Provides patient medication counseling. Yes, of course, a pharmacist is known for counseling patients. Now, whether you are a clinical pharmacist or just a pharmacist, a general pharmacist in the community or at a hospital, clinics, anywhere you practice, we counsel patients on their medications, and there are reasons for that. I'm going to mention it in a minute. On admission, patients get their medication therapy changed most of the time. We take out medications, remove them from their medication lists, add new medications, change doses of previously used medications, etc. And all of that happens to optimize a patient's therapeutic plan, and most of the time this happens on admission. So the patient is not aware of what we're doing because we just ordered stuff, changed stuff, and the nurse would go in and give the new doses of medications, like a few pills every how many hours, and the patient will just take them. They don't know what's happening, right? They're getting better, that for sure, but they don't know what changes we made. Imagine this scenario. We made a lot of changes to medications to any patient, and then the patient got discharged from the hospital with went back home and started using the medications that were previously prescribed, and then they got worse and get readmitted to the hospital. What's the reason for readmission? The patient used the medications that were prescribed before their admission. So at the old prescribed doses, different medications. I mean, we might have changed in many of them, and so on. So if the patient is not aware of the changes that we made, we can't really blame them, right? They went outside and went back home and they used their old medications. But if we had counseled them before discharge and told them, hey, we stopped your warfarin because it almost made you bleed, or it actually caused a bleeding, and we switched you to another drug called the Bixaban, for example, to control your or to avoid a stroke from your AFib. We reduced your amlodipines dose because you were hypotensive when you came in. Stuff like that. If we talk to the patient before they get discharged and tell them all that stuff, it will avoid a lot of trouble and a lot of readmissions from therapeutic failure. Another example is that we see a lot in hospitals is a patient that gets admitted for COPD exacerbation. Let's say this patient was not using any puffers before they came into the hospital, and now we do PFTs, which is pulmonary function tests, and the patient gets diagnosed with COPD, which is chronic obstructive pulmonary disease. You should know that. I'm speaking to clinical pharmacists on this channel, so you should know what COPD is. So let's say we rounded on that patient. We decided to put the patient on puffers. The patient was not on puffers before they came to us, so this is a new medication for them. We started to teach the patient on how to use the buffer, which would be the ideal scenario. A pharmacist or the nurse would walk in and show the patient the puffer and how to use it, and give them some instruction sheets to look at and read. What to do if there's a corticosteroid in the puffer, what to do after using the puffer, and so on. But imagine that we didn't do that. We didn't counsel the patient at all. We gave them the puffer and discharged them from the emergency department right away. The patient will go home not understanding what to do with the puffer. They will just try to figure it out. They might use it the wrong way. And we see that a lot with puffers. And this will just, in a few days, it will end up in the patient getting another exacerbation of COPD, and they'll get readmitted to the hospital for therapy failure. Now, in order to avoid all that, we should be counseling the patient before discharge about all medication changes that happened on them. Now, just to be more clear on that, this depends on how many clinical pharmacists are on duty on any single day, because most of the time we are extremely short of staff. So if you're the only clinical pharmacist covering the whole hospital, it would be impossible to counsel every single patient being discharged on that day. And most of those patients will have medication changes. And that's where we rely a lot on nursing staff, for sure, to help us with patient counseling, but also on physicians to alert us on really major drug changes on any single patient, and to write in the chart, pharmacist to please counsel the patient before discharge, so that I would know that this patient had major changes on their medications. Because if you're the only pharmacist or clinical pharmacist at the hospital, it's impossible that you will make it to rounds on every single floor. There are so many floors, there are so many wards on each floor, so you can't. You're just one person, right? And this happens in North America. Sometimes we are extremely short of staff. There are sick leaves, and there are other special leaves that would leave you as the only pharmacist in the hospital, which is not ideal for sure. But yeah, unless you have enough staff to back you up, then only you can go in and do the counseling part, which is unfortunate, but it is the ugly truth in North America. We're extremely short of staff. So anyways, there are so many other duties and responsibilities, but this video has gone over 20 minutes now. I don't want it to be too boring. Stay tuned for part 2 of this video, which should come out very soon. I'll try to finish all the duties and responsibilities in the next video. Once again, I remind you, if you're new on this channel and this topic or clinical pharmacy topic interests you, make sure to subscribe to the channel and hit the like button if you liked the content that you saw today. It really supports my channel and supports me to make more videos, provide you with more information. There will be so many more videos about our day-to-day operations as clinical pharmacists in North America. So hopefully this will help you improve and advance your career like we did with so many other pharmacists around the world. Once again, thanks for watching, and I'll see you in the next video.